I'd like to introduce my namesake. This is Manny Pardo, and I'm Manny Vallejo. So we're not brothers, but we do have the same name. But anyhow, Manny Pardo is the anesthesia residency director at UCSF, and he's going to speak on sepsis. Thank you.
Thank you, Manny. Other Manny. It's a pleasure to be here. I think the last time that I was at this meeting was when Saul Shnider was still alive. And I was a resident. Saul died when I was a second-year resident, and as a first-year resident, we were allowed to go to this meeting. So that's probably the last time I was here. When Bob invited me, and by the way, I was very appreciative of Bob's invitation, I told Bob, I have an extremely limited OB anesthesia practice. My OB anesthesia practice is limited to the critically ill. Anybody who requires ICU care, because in my clinical work, I'm an intensivist and anesthesiologist, but my obstetric practice is limited to the critically ill, hence this presentation. I have no relevant financial disclosures. So I'm going to be going over two aspects of sepsis in pregnancy. Number one, issues with diagnosis, and number two, treatment. If I was an actor, I would be a method actor, and in that sense, I would immerse myself in the roles like Dustin Hoffman and Rain Man. And for this talk, which is again something that I don't normally talk about to an audience of obstetric anesthesiologists, I immersed myself in this topic by doing something very old-fashioned. I went to the medical library at UCSF and I found a book, an old-fashioned paper book. Actually, it was a hardback book. It was titled The Tragedy of Childbed Fever, and it outlined the history of sepsis in pregnancy from the 18th and 19th century onwards. It's quite fascinating and sobering to read. In the 18th and 19th century, Europe and the United States, sepsis was the #1 cause of maternal mortality, with a mortality rate of 250 per 100,000 live births. As you look at how this has evolved over time, this is data on maternal mortality from the UK. And on the far left on the graph is the year 1850, and that's about 250 deaths per 100,000 live births. And you can see that this goes down markedly in the mid 1900s, about 1950. This is generally acknowledged to be due to the discovery and use of sulfa broad-spectrum antibiotics, and possibly also from decreased virulence from strep pyogenes. However, if you look more closely at this graph, and now this graph is again from the UK, the left side of the graph is about 1970 and the right side is 2008, you'll see that though there's been a drop since the 70s over the last say 10 years in the UK, the incidence of maternal mortality from sepsis has actually been increasing slightly. Let's look at data from the United States. This is data from the CDC from 1987 to 2012. I know other speakers have showed a graph similar to this, showing a maternal mortality rate on the most recent data in 2012 of 16 per 100,000 live births. Dr. Hawkins showed you a version of this graph showing the causes of pregnancy-related death in the United States. And here sepsis represents 13%. So if we combine the previous graph with that 13%, we get a rate of about 2 deaths per 100,000 live births, so maternal mortality attributable to sepsis in the United States. So that's the magnitude of the problem currently. I'd like to go over now what I call the saga of sepsis definitions. And I'll tell you that intensivists love numbers, we love scoring systems. So there's a little bit of that I'll share with you. But the saga begins as far back as the 1850s. This is a German postage stamp of the famous obstetrician Semmelweis, who is credited for promoting the use of hand washing in medical care. It's actually quite an interesting story. He promoted hand washing essentially in a way for the wrong reason. His theory was that childbed fever or puerperal sepsis, whatever you want to call it, was caused by cadaverous particles that were transported from from cadavers to patients. And he made an observation. He worked at 2 maternity hospitals. And it's interesting because it ended up being a randomized trial. It depended on the day of the week which hospital the pregnant women went to. In one hospital, there were just midwives. In the other hospital, there were medical students as well. And then the medical students would often go from the cadaver lab, and again, the era of not hand washing, cadaver lab to the delivery ward. And so when he compared the rates of sepsis, they were much higher in the hospital that had the medical students handling cadavers before examining patients. Now, interestingly, what brought him to the conclusion that cadaverous particles was one of his colleagues cut himself in the cadaver lab and had the same illness that these women had, and so he hypothesized that it was cadaverous particles that caused this. So the definition that most of us learned is that sepsis is the systemic response to infection. So again, intensivists like to have scoring systems, and this was the first thing that came about in the early 90s. This was the definition of systemic inflammatory response syndrome, or SIRS. I think many of us in this room have learned this term, and the definition of sepsis used to be an infection plus 2 of these 4 signs of SIRS means you have sepsis, systemic response to infection. And what were the parameters here? There were 4 parameters: temperature, heart rate, respiratory rate, and white count. So simple, 2 of these 4 things plus an infection, and then you had sepsis. However, in retrospect, that was probably quite an oversimplification, because these signs are quite nonspecific. There are many reasons why patients may have fever, hypothermia, tachycardia, tachypnea, or elevated or low white count. And in fact, many of these are just appropriate responses. So when I prepared these slides, this was about a month ago, and I was going to define for you, actually before I get to that, with the SIRS criteria. With the SIRS criteria, there's some specific challenges in pregnancy. So let's take the 4 SIRS criteria, temperature, heart rate, respiratory rate, and white count, and just look at what happens in pregnancy. Well, I think you had a talk about labor epidurals and fever. There's an association. The heart rate obviously can increase markedly. Well, it increases during pregnancy and markedly increases during labor. The respiratory rate, again, also increased during pregnancy and during labor. And the white count can be increased. So essentially every parameter is altered of these parameters that are typically used to diagnose sepsis. Hence, one of the challenges of diagnosing sepsis in pregnancy. So when I made these slides, I was going to go over 5 sepsis-related definitions, because again, intensivists like to define things. And then what happened was I turned in my slides for CME review, and a week later, there was an article in JAMA that came out with brand new sepsis definitions. This is 3 days before our slides were due. So I said to myself, I have to make this up to date for this meeting to be state-of-the-art and current. So I did that. So that's why you see a red X in front of several of my slides here. So I was going to define for you sepsis, severe sepsis, sepsis-induced hypotension, septic shock, and sepsis-induced tissue hypoperfusion. Fortunately, there are now only 2 of these 5 that you have to know of these terms. So I'm going to just tell you we just saved ourselves about 5 or 10 minutes going through these. And the definition used to be you have an infection, and plus you pick some of these. It's almost like a Chinese menu. You pick some of these things, and the list is longer now, and then you'd have sepsis. So I'm going to skip through these. However, one of the things that you look at here is the organ dysfunction, so various markers of organ dysfunction or tissue perfusion issues. And then the definitions of severe sepsis had to do, again, with cardiovascular manifestations, et cetera. Fortunately, the new definitions are considerably simpler, so I'm going to go right through them. So here was this page in JAMA, and in a way, although I had to do extra work to prepare this, I was actually pleased to do it because it's actually a little bit simpler and makes more sense now. So let's go over the actual brand new February 22nd, 2016 definitions of sepsis and septic shock. So first, the definition of sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. There are a few very loaded terms in this definition. I'm going to go over 3 of them. The first is the term life-threatening. So the idea of life-threatening is the investigators that came up with the new sepsis definition wanted to have an association with mortality. And so the criteria that they came up with are actually associated with increased mortality. They did this based on a review of 28,000 records, and they validated the mortality increase in an electronic medical record database of over 1 million records. So this is really a key part of the definition. This definition, if you meet the definition of sepsis, you have increased mortality. The second aspect is organ dysfunction, that it's clear that cellular dysfunction is a key aspect of sepsis and underlies many of the abnormalities. And the term dysregulated host response. Again, many of the SIRS criteria could be appropriate adaptive responses. The idea of a dysregulated response means that there's just more complex interactions than simply inflammation alone. This is a graph from a New England Journal of Medicine review article outlining the complex host response to sepsis. And all I want you to take away from this very nice color diagram is, number 1, it's very complicated. Number 2, the top red bar says pro-inflammatory response. And this was our classic thought about sepsis. Sepsis is too much inflammation, too many inflammatory mediators, and that's the main thing. The bottom part in green, however, is what we appreciate more now, is that sepsis also includes an anti-inflammatory, i.e. an immunosuppressive response, typically later on in the course, but how it presents is different in different individuals. So it's really complex, but dysregulation is the key. Now, there is one score that you do have to remember now. Can't escape any scores if you're an intensivist. It's called the SOFA score. SOFA, Sequential Sepsis-Related Organ Failure Assessment Score, SOFA. It's a 24-point score looking at organ dysfunction in one of 6 areas. I'm going to go over the 6 areas in brief so you get some sense of what this refers to. If you have a change, and so the criteria is infection plus an increase in at least 2 SOFA points after the onset of the infection. If you have an increase in 2 points, your mortality is up by 10% already. So that's a big change to say your mortality just went up 10% by meeting this criteria. Again, validated in over 1 million patients. So let's go over the 6 organ systems. I'll give you a sense for how you can count this. So lungs, the marker is the PaO2 to FiO2 ratio. And so 0 points is a PF ratio of greater than 400. And on the other side, with 4 points, is a PaO2 to FiO2 ratio of less than 100. Cardiovascular manifestations have to do with hypotension, both with the MAP criteria and criteria for being on pressors and which pressors. In other words, if it's just dobutamine or norepinephrine, that would put you at a different part of this SOFA score. The coagulation score has to do with the platelet count. And again, this is the delta score. So if a patient came in with somewhat low platelets, it's did they get lower and what's the delta score, and not the initial score. Same thing with the CNS. The Glasgow Coma score is used for that. And the liver uses bilirubin, and then the renal is creatinine. So greater than 2, a delta greater than 2 in combination with infection is sepsis. Septic shock is defined as a subset of patients with sepsis in which the underlying circulatory and cellular abnormalities are profound enough to substantially increase mortality. So there again is that word mortality in the definition. And again, this is key because if you diagnose somebody with septic shock now, you are essentially saying their mortality is at least 40% if they have septic shock. Again, another slide from the New England Journal Review article showing some of the circulatory and cellular abnormalities in sepsis. Number one, it's complicated. Number two, the end result is tissue hyperperfusion and tissue hypoxia. As far as the clinical criteria, they're actually quite straightforward. You meet the criteria for sepsis, plus you have both persistent hypotension with the requirement for vasopressors to keep a MAP above 65, and you have an elevated lactate of greater than 2 despite adequate volume resuscitation. So again, you meet the criteria for septic shock, the mortality rate is at least 40%. So what causes sepsis in pregnancy? Well, the classic sources of infection are the genitourinary tract and the cesarean section, essentially the site of the birth, the cesarean section or vaginal delivery. And then there are kind of non-obstetric, such as pulmonary causes, pneumonia, and then non-obstetric intraperitoneal causes, appendicitis, etc. But the classic is the genitourinary tract or the cesarean or vaginal delivery site. The next two graphs come from review articles on risk factors for sepsis in pregnancy. The first comes from the UK, and I'm actually going to skip to the American one. They're actually pretty similar. Risk factors for severe morbidity and mortality in sepsis. Essentially, the keys here are anything that interferes with a normal barrier, such as a cesarean section or the actual birth, and then anything that reduces your immunity, whether it's a disease like diabetes or whether it's having prior infection with, say, streptococcal disease. What pathogens are likely? The classic is group A strep, and also group B strep, and then E. coli, or probably those are the most lethal ones, but also it's possible to have gram-negative organisms and anaerobes. So one note about the fetal evaluation in sepsis, it's common to have fetal tachycardia, reduced variability, and decelerations. The decision for delivery is based on the usual factors, the gestational age, the fetal status, and the maternal status, including whether the source of the infection would be treatable with delivery or not, and the particular manifestations of sepsis. So the classic approach to sepsis, which is what I learned in the mid-90s, and I think many of you learned, is really a kind of five aspects or 5 steps in the process, the paradigm for managing sepsis. Number one, diagnose sepsis. Number two, stabilize the patient. Number 3, identify and control the source of infection. Number 4, give the right antibiotics quickly. And number 5, watch for and treat any complications. So these 5 things, this paradigm is still fine. But within this paradigm, there are a lot of things that have been tried and attempted in the management of sepsis. I've seen many of them even in my relatively short time, since I was an ICU fellow in the mid-90s. So let's just take the whole aspect of stabilizing the patient. All these things here, so for example, which fluid do you give and how much and when, how early, the whole idea of early goal-directed therapy. Is that the right thing to stabilize the patient? Do you put a central line in or not? Do you use central venous saturation? Do you guide therapy or not? Do you give blood transfusions or not? And at one level, do you use PA catheters to optimize the oxygen delivery? Which pressors are the best? How do you control the glucose? Each of these things, there are many clinical trials in the ICU about. Another aspect having to do with managing specific complications and surgery versus interventional radiology. So you get the idea. There are a lot of complicated aspects to that basic paradigm of sepsis management. So there have been guidelines for this, guidelines that have been promulgated by the Society for Critical Care Medicine and the European counterpart. And there have been a series of evidence-based guidelines that have come out actually every election year for the last 3 years, 2004, 2008, 2012, and I don't think that's probably a coincidence. And the idea is that they've produced a core set of bundles, a bundle of things, a set of things that you do, these sort of key aspects of managing sepsis. Here is the key parts of the latest bundle, the 2015 Surviving Sepsis Campaign bundle. And so these are 4 things that you should complete within 3 hours of presentation. Now, the 3 hours actually applies to the emergency department. If they're an inpatient, this should be within 1 hour of presentation if it's an inpatient. So the 4 things are: measure the lactate, obtain blood cultures before antibiotics, administer broad-spectrum antibiotics, and administer 30 mLs per kilo of crystalloid for either hypotension or for elevated lactate. That's all that's in the bundle. Those are the key things. The idea behind the bundle is that you need to do at least these things. And doing other things, spending all this time putting central lines and other lines in and not doing those 4 things is the wrong management. There's a significant mortality risk at delaying antibiotics. If antibiotics, and this is timing of antibiotics from the onset of hypotension. The furthest left data point you see is 1 to 2 hours after hypotension onset, and the farthest point on the right is over 36 hours from onset. So going from 1 to 2 to 8 hours is a 10-fold difference in mortality for delaying. So you delay the antibiotics 6 to 8 hours, 10 times increased risk of death. The other part of the bundle has to do with some things that need to be done within 6 hours of presentation, such as giving vasopressors for hypotension not responsive to pressors, and reassessing the volume status if there's persistent hypotension, and then also remeasuring the lactate to see if it's cleared. And as far as how to assess the volume status, you either do a clinical exam or you do measurement of central venous pressure, central venous sat, bedside ultrasound, or fluid responsiveness tests like leg raising. So you don't have to put in a central line, but you must do either one of these 2. So over the last 5 years at UCSF, we've had experience with developing our own sepsis bundle, even before the Surviving Sepsis Campaign bundles had come out. And we have what is called a code sepsis. So our electronic medical record flags some variables, and a screen will pop up and says, this patient, a code sepsis. It alerts a whole bunch of people, including the rapid response team. And there's some screening tools and some prompts for management. So with this approach of having this code sepsis and a team that responds, our sepsis mortality has actually been reduced in the last 4 years since we started measuring and acting on it. I'd like to conclude with sharing a case of sepsis in pregnancy that came from my own experience. And to prepare for this presentation, I took a look at our clinical database of how many of our obstetric patients actually required ICU care. I looked at a 5-year period, and I found 38 patients needed ICU care. We have about 3,000 deliveries a year, so that's 38 out of 15,000. That's about 1 in 2,500 needing ICU care. And of those, there were 6 that had sepsis. So 1 in 400 is the ICU admission rate. 1 in 2,500 is the rate of admission with sepsis. None of them died. So this is based on one of the patients that I took care of. So I'll go over the patient's clinical course. This is a 30-year-old G2P0 at 24 weeks with twins who was admitted with vaginal bleeding. Ultrasound showed no previa, but there was a subchorionic hematoma, and the initial labs just showed a mild increase in white count, probably normal for pregnancy, and otherwise unremarkable. On hospital day 2, there was premature rupture of membranes for the twin A, and then in the next day for twin B, and unfortunately intrauterine fetal demise. Later that day, the patient had a fever and underwent counseling regarding D&E versus trial of labor. The day after that, the white count increased and the patient had rigors, but no fever. A heart rate went up to 160. Cefotaxime was given because of suspected chorioamnionitis. The patient had a venous blood gas showing acidosis, for which he received several liters of fluid with improvement in the heart rate. Antibiotics were given, as I mentioned, and an epidural was placed and labor was induced. Patient delivered but had retained products of conception, so a curettage was done with a small amount of additional blood loss and some additional IV fluids. However, over the several hours after the curettage, the patient developed significant hypotension with a blood pressure of 70/40, increase in the heart rate, low hematocrit for which she received transfusion, altered mental status. She received additional fluids. She also had broader antibiotics, Amgen and Clinda, and blood cultures. Despite all that, her blood pressure was still low, and so she was transferred to the ICU. I saw her the following day, and by the next day, her vital signs were much improved. 37.4, no fever, blood pressure improved, heart rate lower, and minimal need for oxygen. The notable labs included a lactate of 1.6, which was within the normal range for our lab, and an improved ABG not showing acidosis. She did not need vasopressors, and by the following day, after having remained stable, she was transferred back to the ward. So I'll conclude this talk by analyzing the management of this patient with sepsis, and this will go over some of the key points from this presentation. So number one, this patient had some classic risk factors for sepsis and pregnancy, namely prolonged premature rupture of membranes and a subchorionic hematoma, i.e. a nidus 4 infection. Number two, the patient was diagnosed. She met the criteria for sepsis. She had a source of infection, chorioamnionitis, and had a SOFA score of 2 points, 3 points, 2 for altered mental status and 1 for the blood pressure. She was diagnosed, there was a differential diagnosis that was done. For example, the patient had an ultrasound to rule out further bleeding and with serial hematocrits. Of the surviving sepsis campaign bundle, we didn't measure initial lactate, but we did measure it afterwards. However, she met all the other criteria, including getting blood cultures prior to antibiotics, getting appropriate broad spectrum antibiotics, and getting appropriate fluid. She never required pressors. So that's my summary of the case and also my conclusion for this presentation. Thank you.